Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent from developing and improve from suffering with brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a physician and Chief Scientific Wellness Officer at Kemper Cognitive Wellness, and I'll be your guide on these sound waves. So whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have a loved one with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's, dementia, and just generally things in life's second half. If you have questions or comments, check us out on social media. To support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show if you find these episodes valuable. That's Patreon, Patreon, patreon.com/evolvingpast. So here we go. Let's get better. Welcome back to the show. I have another great guest for you. Our guest this week is Dr. Michael Fossel. He received his MD and PhD from Stanford University, where he was a professor of medicine for several years. He has published numerous articles in both high-impact medical journals as well as popular press. He lectures all over the world and is the former editor-in-chief of the Journal of Anti-Aging. He is one of the world's foremost experts on telomeres and telomere therapy. His book, The Telomerase Revolution, was hailed by the Wall Street Journal as one of the 5 best science books of 2015. Welcome to the show, Michael.
Thanks, Nate. I have to correct you. I actually was not a professor of medicine at Stanford. It was an interesting story. I was finishing a PhD and actually lecturing in the medical school, and they told me I could be a lecturer or a faculty member. And I said, well, being a faculty member sounds very good. Why would I want to be a lecturer? And they pointed out that faculty members didn't get free tuition in those days, but lecturers did. And I said, I would like to be a lecturer. So I ended up getting a free MD in 2.5 years, and that was delightful. Couldn't have been happier.
Well, in 2.5 years?
Yeah, I was teaching some of the courses. I was teaching some of the neurobiology courses and some other courses. It was a lot of fun. I enjoyed doing it. But yeah, 2.5 years.
It's interesting. My mom went to medical school in the 1970s, and in those years, they were trying to, I guess, crank doctors out quicker. So it was a 3-year program.
Right.
I don't know if it was similar to the program you did there.
Well, it was actually an interesting time. At first, I had been doing a bachelor's degree back east, and I discovered that they were charging by the amount of time you were there, not by the credits. So I said to my university, so if I just double up the credits, it doesn't cost anymore, does it? They said, well, that's true. I said, so if I get a free master's, it doesn't cost anything, does it? They said, well, that's true. And they changed that rule the day I left.
Right.
And then I ended up going off to graduate school because I was talked into it. I did, in those days, there were GREs, still GREs, and the score came back and I could not figure out where the numerator was over the denominator. The denominator in those days was 800, and I couldn't figure out where the numerator was. And so I took it to my advisor. He said, well, you missed it. Your numerator is 800. You got perfect scores in the GREs. You should go to graduate school. So I borrowed a couple of applications, drove a moving truck out to California, hitchhiked up the coast, and went to Stanford. Just the story of my life.
So I'm talking with someone with some aptitude.
Well, at least in getting through tests, that doesn't prove anything. We have all met people who've gotten through tests just fine, and you wouldn't trust them to tie your shoes, let alone weed your garden. So, yes, it surprised me. I couldn't figure out what had happened. The advisor said to me, well, actually, you may not know it, but you're actually fairly bright. So I appreciated that. But
yeah.
That's how I ended up doing all this.
So let's start with the kind of the central question and it open up from there. This is obviously a show where we're really interested in cognitive impairment and aging and specifically Alzheimer's disease. I got to know you very briefly a couple of years ago when I was still at the Cleveland Clinic around some of the potential trials your group was going to do around Alzheimer's disease. What specifically are you proposing about Alzheimer's disease? And if that isn't the right first question, please guide me to our way into this conversation.
I know what you mean, but I think it is the right question, although you're right. Sometimes the problem is asking the right question, not answering it. But you're right. The answer is we think we can actually prevent and cure Alzheimer's disease. But to do that always demands that you understand what it is you're trying to do. I'll give you an example. Say that we're trying to cure Ebola disease, but we don't know what it is. We know that people throw up and they have bleeding and they have fevers and they have high white counts. But unless we understand that it's a viral disease, we'll be treating symptoms. That is, we'll be treating components rather than the system. But the same thing is really true with regard to Alzheimer's disease. To understand it requires that you step back. Rather than just move forward, you have to step back and say, what's really going on here? What causes this? What's going on? And too often in the past, easily 20 years, but really the past 100 years, we have focused on components, for example, beta amyloid, for example, tau tangles, for example, mitochondrial dysfunction, without saying, how do they relate? And that's really the key here. Here's another example. We know that closed head injuries, traumatic brain injuries, increase your risk of Alzheimer's. All right, but why does that happen? We know that there are literally dozens of genes. I mean, I could start by listing a couple of them, but there are dozens, starting with things like the double allele APOE4, increase your risk of Alzheimer's. Well, why? We know that infections of the brain can increase, whether it's bacterial, viral, fungal, prion, can increase your risk of Alzheimer's. But why? We also know that if you look at Alzheimer's disease, there are a number of changes that occur. As I've said, beta amyloid and tau tangles and mitochondrial dysfunction and inflammation. But why? What we don't know is what goes on in the black box in between. And that's critical because otherwise what you're doing, again, like trying to treat Ebola, if all you do is treat nausea, you're not really going to increase people's chances of survival. If all you're treating is bleeding, likewise. What you have to do is step back, say, oh, it's a viral disease. We need to have an immunization. But the same thing in parallel is true here. We need to step back and say, what is really going on that makes Alzheimer's happen? And only then can we figure out where the most effective point of intervention. The classic example is aging. We know that aging is the single most important risk factor for Alzheimer's disease. You do find 45-year-old people with Alzheimer's.
Yes.
You do even find people with 30-year-olds with Alzheimer's. I remember with regard to heart disease, seeing a 25-year-old with a heart attack. That's unusual. It's not unheard of. It's just very unusual. In general, aging is a risk factor for Alzheimer's and heart disease. But why? Why does that happen? I found, back in the old days in Stanford, I was actually teaching courses on neurobiology, and my interest was developmental neurobiology. How does the nervous system go together? And I don't know anybody with any sense who doesn't look at the development of the nervous system and find themselves impressed. It is every bit as awesome to me as looking at the spiral galaxies and just being impressed by the universe. The way the nervous system puts itself together is just awesome to me. It just absolutely floors me.
Exquisite. Yeah.
Yes, it is. But I found that when I turn to people and say, what about aging and age-related diseases? People would shrug their shoulders and say, well, that just happens. I mean, what do you expect? People get old, they rust, things fall apart, entropy. And I thought that's an awfully blasé attitude. And I think that's true. We tend to assume that aging, quote, just happens without asking how it happens. Len Hayflick and I were having this discussion a couple of months ago, and he said, it's funny how people who will tell you that aging is the single major risk factor for their favorite age-related disease, whatever it is they focus on, will then ignore aging itself. They'll say it's the central risk factor, but then they'll ignore it. That's the problem here with Alzheimer's disease, not only with regard to aging, but everything else. We need a model. When I put this paper, this was kind of an interesting paper. I didn't intend to write it. I got talked into giving this talk, then talked into giving the paper. But for me, the rationale was to give us some leverage to explain to people why what we're doing makes sense.
And I just want to stop you there, Michael.
Please.
Are you referring to the unified model paper?
I am. This just came out less than a week ago. It's an interesting paper because it's already had more than 300. I think we're approaching 400 reprint requests, and the paper hasn't even been out a week.
This is the paper entitled A Unified Model of Dementias and Age-Related Neurodegeneration?
Yes.
Can you just give a synopsis of that for our audience, in case they're not familiar?
Yes. What I'm saying is that there is a unified model, that if you want to understand Alzheimer's, you also have to understand Parkinson's and frontotemporal dementia and Lewy body dementia and a number of other dementias, as well as explaining why it is that animals have cognitive decline. Older cats and older dogs have cognitive decline. Why is that? All of these things are of a piece. They all fit together. And it's not enough to simply try to wave your hands and say, well, it's beta amyloid, without
Mhm.
stepping back and say, why is it beta amyloid? Why do other age-related dementias, Parkinson's, for example, occur? Why do animals, cats, dogs, mice, show cognitive decline? I think we need a model that explains all of that. So that's where the paper came from.
My reading of the paper is that I think that you may have found a model that explains that.
Well, I think so. But frankly, I'd be surprised if the model was perfect. I think the model is good and it's good enough to test, and it's probably accurate enough to give us a handle on how to intervene, how to actually prevent and cure Alzheimer's. I'd be surprised if it was 100% accurate, but what model is? I think it's like looking back at, and I don't mean to sound uppity about this, but it's like looking back at early quantum physics. The model was not right, but it was a better model than classical physics, and most people didn't believe it. They had a hard time understanding it and a hard time conceiving that the world could be that complex. But it is. The world is complicated. And there's an irony here, too. What I think, Nate, is that, if you view aging and Alzheimer's as simple, that is, it just happens, beta amyloid causes it, then you won't be able to solve it, you won't be able to cure it, you won't be able to prevent it. But if you, again, ironically, if you realize the complexity, things become simpler. Once you understand how complex it is, you can do something about it. In the old days with classical physics, there was a lot we couldn't explain. And that was why we couldn't do things like have cell phones and GPS and satellites that do what they do now. But once we understood the complexity of it, you could actually do things like have GPS. The same thing is true here. Once you understand the complexity involved in this, I think we can actually cure it.
So that's excellent. So can you explain the central argument of this recent paper vis-a-vis Alzheimer's?
Yes, let me put it in a perspective first. Let's say that there are upstream components and downstream components. The upstream components are things like aging and closed head injuries, exposure to radiation, infections, exposure to toxins. All those things are risk factors. Genetics, all those things are upstream components. They're part of what goes on with dementias, but they're not dementias. They're just part of it. They're risk factors. Downstream, you have things like beta amyloid and tau tangles and all the things we see clinically, confusion, loss of memory. Those are all downstream components, but they're not Alzheimer's. They're just part of it. The question is what goes on between. And what I'm suggesting is that, as cells divide, as telomeres shorten, those are the pieces at the end of chromosomes, as those shorten, they change the pattern of gene expression. And the result is that cells become increasingly dysfunctional. And the result of that, and I could go into detail on all of these, is that you get things like beta amyloid plaques. So think of it as a sort of a waterfall, a cascade of pathology that starts with things like aging and closed head injury and genetics and all those things that play a role, but they're not by themselves the disease. And they go through cell senescence and changes in gene expression and dysfunctional cells. And those are the key parts in the middle. And they result in things like beta amyloid plaques and loss of memory. But those aren't the disease, they're just part of this whole process. The question I have is not really what causes Alzheimer's. I think we need to know that. We really do. But the question I really have is what can we do about it? It's a practical question. From my perspective, the question is not what can we do. For example, one of the things we could do is lower the risk of getting closed head injuries.
Hmm.
We could change your genes. There are lots of things we could try to do, but they're not very effective. My question is, what's the single most effective point of intervention, both clinically and financially? Example, Biogen has spent more than $750 million on anakinumab with little to show for it. And I think the reason is they're aiming at the wrong targets. What are the right targets? Where's the best place to intervene that we can cure something? Back to the example of Ebola. If you have Ebola disease, Ebola virus, we could treat your nausea, we could treat your bleeding, we could treat your blood pressure, we could treat a lot of things. But the most effective place to treat it would be an immunization that stopped the virus infection. And I think that's the kind of question that we need to ask with Alzheimer's. It's not, can we treat beta amyloid? Well, we can try. Can we treat tau tangles? Well, we can try. But where's the most effective point? Where's the place where we can really stop it cold? And the most effective point from my perspective turns out to be cell senescence and changing gene expression.
Can you define cell senescence, please?
What it really is that if I take a typical human cell, if I take one of your skin cells and I let it divide repeatedly, as it does naturally, it changes its pattern of gene expression and becomes more and more dysfunctional as you and I get older, which is why we get things like wrinkle and thin skin and poor healing, et cetera, in our skin, as an example. That's part of cell senescence. Now, a lot of times scientists think of cell senescence, mistakenly in some sense, as replicative senescence, which is to say, as you get really old, some of these cells refuse to divide anymore and refuse to replace other missing cells. That's replicative senescence, but that's sort of an end result. But this whole process of cell senescence occurs throughout your life. Give me an example of this. If I look at the skin around my face and I look at a little wrinkle at the corner of my mouth, you might say, why does that happen? And the answer is, well, the elastin and the collagen molecules are damaged. But a lot of people, without even thinking about it, assume that when I was, say, 9 years old, those collagen and elastin molecules were there, and over time they get damaged. But that's not true. They're continually being replaced and turned over. The difference is that when I'm 9 years old, they're being turned over very rapidly, which is why damage doesn't sit around very long. But I'm 69 years old, and the damage now sits around a little longer. So anytime I'm looking at a collagen or an elastin molecule, it doesn't work as well as it did when I was 9, not because it's been there for 60 years, but because it's not being turned over as fast. And the outcome is wrinkles. From a more important perspective, if I look at my brain and I say, what's going on in my glial cells in my brain or my neurons in my brain, the same thing pertains. What you're finding is that their way of dealing with, for example, beta amyloid molecules is different than it was when I was 9 years old. The outcome is higher risk of Alzheimer's.
Okay, so I think I grokked what you said there. So moving to Alzheimer's or dementias in general, because there's many similar pathways that you've sort of fundamental upstream mechanisms, as it were, that can result in this cells not being turned over enough as part of the spectrum of cell senescence.
Well, it's not just the cells being turned over, it's the molecules themselves. So to take an example of beta amyloid, I mean, everybody generally, many people are aware that you get beta amyloid plaques with Alzheimer's, which is roughly true. But if you look at the beta amyloid, what you find is that in a young person, it's turned over very quickly, whereas in an older person, it's produced more slowly and bound more slowly, brought back into the cell more slowly, and degraded more slowly. So, as it were, the recycling is slower. I give you an example of this. Say I have a car that I take care of once every week. I thoroughly go over it, make sure that everything is dealt with, the gas, the oil, the alignment, you name it, I've dealt with it. That car will stay in good shape. Say instead of that, I take care of that car once every 10 years. Well, that car's not going to function very well. It's the rate of maintenance that makes all the difference. So that's kind of what's going on with your cells. It's not the fact that you have a gene that increases your risk of beta amyloid plaques. The fact is the turnover rate is so slow that you begin to get accumulation of damage.
Mhm. So the next piece here, you've mentioned telomeres and telomerase. Can you briefly explain telomeres and telomerase related to health and aging and certainly cognitive impairment?
Yeah, telomeres are the last several thousand base pairs on the end of your chromosome. And in a sense, they act like a clock. Every time a cell divides, it loses a little piece of the telomere. And by itself, that's not the important thing. It's not that it's the shoelace and then the shoelace unwinds the way that some people use as an analogy. No, the problem is that it changes the pattern of gene expression. So the fact that the telomere is shorter is irrelevant. The fact that the telomere changes gene expression is critical. Let me give you another example of that. The length of the telomere actually doesn't matter. What does matter is the rate at which the telomere is lost. It's not the telomere length in an absolute sense that matters, it's the relative sense that matters. Example, some varieties of mice have telomeres that are literally 10 times longer than mine, and yet their lifespans are 40 times shorter than mine. It's not the telomere length that matters, but when you look at the rate of telomere loss and the changes in gene expression, that sort of defines everything. The changes in gene expression make those mice have 2-year lifespans and make me have, say, an 80-year lifespan. So that's what's going on with telomeres. Telomerase is a molecule, an enzyme actually, that increases the length of telomeres. Normally, you only see this expressed really in germ cells and in some stem cells. There are some other odd cases, but most of your body cells don't express telomerase. So the telomeres shorten, and rather than being reset to the normal length, they just continue to shorten with age. Hence, as we go by the years, those chronologic years translate into physiologic years.
And when I was reading this, you have it's this lengthy paper. It's like a 42-page paper, and of course, people are certainly invited to read the book, The Telomerase Revolution, that you wrote a few years ago.
It's a lot more readable.
Right, definitely more relatable. But you're proposing something very specific. At least the context in which you're providing an argument for this longer paper is not aging in general per se. It is an argument within dementia, right? So how do we avoid, preclude, prevent, or treat dementia, correct?
Well, you're right as far as the paper goes, although in the last few paragraphs of the summary, I pointed out that this same model pertains to cardiovascular disease, osteoarthritis, osteoporosis, age-related renal failure, and so on, skin aging. So the discussion focused on Alzheimer's disease, but the model pertains to all age-related diseases.
Okay. So telomerase therapy not only applies to dementias, but it applied to a wide scope of diseases that are a major burden for our health and our healthcare system.
That's an interesting point. You're right. Let me put this in a little parallel perspective from 1950. Polio was rampant in the United States, the UK, Canada, and there were a lot of people who, reasonably enough, were concerned not about the human costs, which are true, but also about the financial costs. In fact, there were estimates in 1950 that the U.S. healthcare system, as one example, would be bankrupt by the year 2000 because of the cost of rehabilitation, nursing care, braces, iron lungs. These were real concerns in 1950. And yet by 1954, we began to make inroads. Currently, the cost of treating polio worldwide is less than 10 cents per patient. The idea that we would go bankrupt because of polio was reasonable in 1950, but unreasonable as we look back. I think the same thing actually is true with regard to Alzheimer's disease. Currently, most countries, and I mean that, most countries globally, because I've talked to some of the people involved in these decisions, are concerned about the cost of healthcare with regard to Alzheimer's and other age-related diseases between now and the end of the century. In fact, between now and the next 50 years. And the fear is that most healthcare systems, and here I don't just mean private payers, but national healthcare system in the UK and other healthcare systems throughout the world, will be bankrupt because of the cost of treating things like Alzheimer's. I think that that's not what will happen. In fact, as I look back historically, I noticed something very interesting, which is incremental improvements in medicine are costly and don't do much for us. Example, robotic surgery, the latest statin, fourth generation antibiotics. These tend to be useful, but they tend to be relatively expensive and they increase the cost of healthcare. But if I ask what were the truly revolutionary advances in medicine, these were conceptual revolutions. The classic example is microbial theory, which allowed for things like smallpox vaccination, allowed for things like hand washing prior to delivering babies, which cut the cost of maternal death, the percentage of maternal death enormously, aseptic surgery, the first antibiotics, polio vaccines, and so on. All of these things are part and parcel of microbial theory. The interesting thing about that revolution is that not only did it markedly improve the quality of human life and the length of human life, but it actually lowered the cost of healthcare. I think that's where we are with regard to age-related diseases. I think we're about to undergo a revolution in which we don't increase the cost of healthcare, we lower it. We don't merely make trivial advances in the quality of human life, we make enormous and revolutionary advances in the quality of human life. A different time. I think we're about to do something that has never occurred before in human history.
Okay, so now you have to say more, obviously. So what's the what's the answer?
Well, I think we will start with Alzheimer's. We picked Alzheimer's because we think of it as, quote, the high-hanging fruit. I'll give you an example. And I'm going to say this is an odd statement, but it's true. No one ever died of osteoporosis. People die because of osteoporosis, but not directly. That is, if I get osteoporosis, say I'm 85, I fall, I break my hip, I go into the hospital. Now I end up with an infection, and I end up in the ICU, and I die of overwhelming infection. I didn't die of osteoporosis. Osteoporosis is not fatal. It is not pleasant, but it's not fatal per se. So let's say that I turn to you or anyone in our audience tonight, And I said, I have an experimental gene therapy. I don't know what the risks are. I've never tried it before, but I'd like to try it on you for osteoporosis. Most people would say, one, osteoporosis isn't fatal. Two, there are multiple things in the market, and here I'm talking about sort of the clinical global market, that purport to be useful for osteoporosis. I think of things like biphosphonates and calcium. Not that I'm impressed by them, but they're out there.
But they're right. There's some therapies that are approved and seem to work to some degree.
Correct. Well put. I don't think they're dramatically effective, but they're accepted as reasonable things to try. So I think anybody with osteoporosis, if I came to them with an experimental gene therapy of unknown safety risks and efficacy, would say, no, come back in 5 years, let me see what happens first time, and between now and then, and I'll think about it. That's an appropriate response. But if I come to someone and say, I've got an experimental therapy, I think it will work to cure Alzheimer's. Alzheimer's is not only a fatal disease, but the global consensus currently, never mind that there's disagreements about this, but the global consensus is that there is no treatment for it. Again, some people will argue, but that's the consensus. People will leap at this. Not only do people tend to leap at it and join, our registry, but the FDA looks at it the same way. They say, what are the relative risks versus relative benefits? The answer is yes, I'd try it. And that's exactly what I find the patients, same reaction. It's the same reason that so many people will try almost anything experimental for Alzheimer's these days. And I don't blame them. What else is there? You would try almost anything.
Yeah.
So from our perspective, it's an appropriate strategic choice to go for Alzheimer's. It's a fatal disease for which there is no credible alternative at the moment. People will try anything. I would. I include myself in the same category. If you told me that you had reason to think that magic spells would work and I had Alzheimer's, I would try magic spells.
Mm-hmm.
I don't take myself out of that category, and I don't blame people for it. I would feel the same way. I do feel the same way. I think we can do better than that. I think we can demonstrate we can literally cure it.
So can you say more about that? So what is your hypothesis on how this might be curable?
Well, as I said earlier, in some sense, I don't care what causes it. What I want to know is where to intervene. Now, from my perspective, the fact is I need to understand it or I can't intervene. But it's not, I don't view this as an academic or a philosophic issue. It's a practical issue. The question is, what can I do that makes things better? So when I look at Alzheimer's, I'm asking myself, if I look at the upstream components, the risk factors, and the downstream components, that is the sort of the phenotypic expression, the clinical expression of Alzheimer's, I find not very efficient points of intervention. But when I look in between and look at cell senescence, I see several possible points of intervention that should be very effective. I think the single most effective point of intervention is to reset gene expression by re-lengthening telomeres. And as it turns out, that's entirely doable. That's feasible. Not as well as I'd like to, but it's been demonstrated very nicely in not only human cells in the laboratory, human tissues in the laboratory, but animals as well. So that's exactly what we intend to do. We intend to take this to FDA human trials probably next year. It's simply a matter of making sure that we have investors who fund this.
So in your hypothesis here, we're talking about targeting the fundamental upstream mechanisms. And are there any particular cell types you'd go after?
Well, remember, it's not just upstream, but there are even further upstream. As I say, one way to lower your risk is to avoid head injuries, for example. That's pretty far upstream,
Right.
but it's not all that effective. Again, I'm perfectly in favor of seatbelts and football helmets, but it hasn't been as effective as we'd like to. And it certainly doesn't account for people who never had head injuries. So yes, I think that the most effective point is to deal with gene expression, and we can take that to clinical trials and reset gene expression.
Gene expression of all cells or anything specifically?
Well, we'd love to get all cells. And without wanting to get too much into details, the cells we would most like to get are glial cells. There are sort of three major and some minor types of glial cells. These are the cells in your brain that are not just neurons. We'd also like to be able to reset neurons. Our current ability is to reset a very small percentage of neurons, an even smaller percentage of what are called astroglia, and almost none of what we'd most like to get at, which is microglia. And yet we're on the verge of being able to do that too. Having said that, the cells we can get out and the percentages we can get at them have already proved effective in mice. So if we're looking at older mice who have the same problems in some sense that we do, which is inability to learn, inability to remember, same sort of cognitive decline that we see in dementia-related diseases, those can be reset. That was first done in 2011 at a group at Harvard, and then in 2012 by a group in Madrid. And the group in Madrid used a technique that, again, we can take directly to FDA human trials. So essentially, that's what we'll do. There are a few tweaks, and there are enormous concerns we have. If I think about the concerns we have, the first one is credibility, which is we cannot afford to do this wrong because we're talking about doing something that's never been done before. And there have been more than 400 registered FDA trials, all of which, by consensus again, have failed.
Yeah.
So if we were to announce that we succeeded, there's a lot of eye rolling. I was at a meeting last month where Biogen in San Diego was trying to talk about relooking at their data. And there was a lot of disbelief in the audience. Well, that's the kind of disbelief you face when you say we can affect Alzheimer's. So credibility is key for us. After that comes the issue of safety, and it is remarkably difficult to deal with safety issues when you're coming to gene therapy. It sounds simple, but in fact, it's harder than you might imagine.
Why is that?
Well, I'll give you an example of this. Say that I use an AAV9 virus.
Okay. So that's a vector virus that you're using to deliver the therapy into a human cell, right?
Yes, to deliver the therapy. And these are adeno-associated viruses. They've never been shown to cause any significant pathology in human beings. That is, you don't get sick because of them. On the other hand, most of us have seen those. Probably on the average, about 60% of adults in the United States have been exposed to adeno-associated virus. So if I try to treat you with an adeno-associated virus, what happens? Will you have an immune response? Will that immune response be a problem? Will that interfere with efficacy? All good questions. And those are the kind of practical questions that we pay a lot of attention to.
It's what's the limitation from a very early phase human trial, just to observe and see what happens? Do we not have any data on this? Is this a first of its kind?
Well, we do. One of the people who was involved in setting up our protocols actually was the chief scientist at a company called Avexis that set up the first protocol for what's called spinal muscular atrophy. And they took that through FDA. They used an AAV9 virus. And they had it a little easier in that you're dealing with children, in this case with infants, 1 or 2 year olds, in that they've been less exposed to AAV in the past, so that their immune response is less. So there's been a fair amount of data on this, but frankly, there's a lot that's still not known. One of the problems is, as I say, getting it in there so that your immune system doesn't stop it, making sure that the viruses you deliver really have the gene in them, and that's a common problem in production. Making sure that when it's expressed, it actually is expressed in a way that gets the cell to reproduce the enzyme, in this case, the telomerase. There are a lot of tricky technical issues. It's feasible, but it's not easy.
Right. You're sort of going down the rabbit hole on what would be involved and how this therapy works when I kind of asked you to stop and explain that side. I mean, can you talk a little bit more to the evidence that this therapy works, even in animals? Like what kind of things we've seen in animals?
That's an interesting question because it is how this paper started that I put out last week. The Alzheimer's Association asked me to give a talk in Washington. It was a conference on animal models of Alzheimer's. Now, the usual sort of snarky remark, but it's accurate, with regard to animals is that, quote, everything works in mice, nothing works in humans.
Right.
And at the end of the day, I was to summarize the entire day's discussion. And I stood up and I said, listen, I'm not going to summarize it, but I am going to make a point. I mean, you've all heard these lectures. I don't think I need to summarize them, but I do need to summarize a concept, which is, why do we fail? And the answer is, we have techniques like monoclonal antibodies, which is what Eli Lilly and Biogen use. And we have targets like beta amyloid and tau proteins. What we lack is a model to explain how to use those. And until we have a model that explains, for example, what's going on in animals, we won't be able to succeed in either animals or humans. Now, there are certain things that you and I share with mice. There are certain things you and I share with trees. I mean, there are a good percentage of genes you and I have in common with trees, but there are a number we don't. So, for example, mice don't have the same physiology with regard to beta amyloid that you and I do. So anytime you're looking at beta amyloid models, they tend to fail when you try to translate them to human beings. On the other hand, there are certain things that you and I share completely. with mice. Among them, telomerase mechanism. Their telomeres may be a little longer, but the mechanism is the same. The way that it changes gene expression is the same. So when I gave that talk, I said, what we need is a universal model. I didn't explain what my model might be. Afterwards, I was surprised to find I was mobbed by a dozen, 2 dozen people who complimented me on what I'd said. And one person said, yes, and I'd like you to write up your model. And that turned out to be the editor-in-chief of the Alzheimer's and Dementia Journal. So that's where we went from there.
So that's so interesting. So then going back to what we were talking about before, which is the actual therapeutic that we're talking about, the actual treatment that we're talking about, we're talking about one potential, or maybe the first, most logical potential target to intervene on within a human being is their glial cells. And you explain that there are different types of glial cells. Why are glial cells, or what about glial cells, make them reasonable candidates to be the target of these telomerase therapies?
Well, think of glial cells as the cells that support, in a real physiologic sense, the support neurons. That is, they take care of the neurons. Think of them as the housekeepers. They do a lot more than that, but it's not a bad analogy to start with. And again, as an example, say I have a housekeeper that takes care of my house. Again, if I take care of my house once a week, things do well. If I take care of it once in 10 years, the house goes straight to hell. That's true of the glial cells too, in some sense. And again, it's more complicated than this, but they take care of the neurons. If they take care of the neurons in a very rapid way, things do well. For example, the turnover of beta amyloid molecules. But if they do it in a very slow, sort of lackadaisical way, then the neuron will suffer for it. So that's one of the reasons that the glial cells are an important target. The neurons turn out to be an important target too. It turns out that, you and I went off to medical school. We learned, among other things, that neurons don't divide. Well, they do, even in the adult. Not many, but some do. And that plays a role in the neuron cell senescence as well. But more realistically, they're dependent on glial cells. So if we can affect glial cells, we can affect the health of neurons.
Interesting. And at what point in a disease course, or maybe not a disease course, maybe you're just targeting people that are at risk, at what point does it make sense that this type of therapy, and again, hypothetically, because I know this hasn't been tested yet, hypothetically, at what point in a disease course would this be effective?
Well, you might think that what you'd like to do is treat it before it happens. So, example, if I knew I had a double allele of what's called ApoE4 that is a high risk, and a family history of Alzheimer's and other indications that I might have Alzheimer's, I'd want to treat it before it ever started. True.
Yes.
But I've been on global recruitment calls, and most companies are looking, and here I mean big pharma and little biotech companies worldwide, are looking for the same patients that I just described. They're looking for somebody who has a lot of risk factors, but has no clinical Alzheimer's. And their thought is that maybe they can slow it if they catch it early. And they're fairly honest about that. Most companies will tell you that they don't think that they can reverse it. They don't think it can stop it, but they think it can slow it if, as it were, they catch it before the first little pebble begins the avalanche. Slow it down. So they're looking for patients who don't have Alzheimer's but will. And those are very difficult patients to find for a number of reasons, and they're highly sought. We're not. We're actually looking for patients with moderate Alzheimer's, and the rationale is sort of interesting. One is, if it ain't broke, I can't fix it. That is, if somebody doesn't have Alzheimer's, I can't fix it. I think we can fix it. I think we can actually reverse some of the cognitive decline. I can't do that unless they have cognitive decline. So I'm looking for patients with moderate Alzheimer's. The second reason is a sort of a strategic one, which is, as I said, there have been more than 400 trials. All have failed. And I think about the problem that Biogen ran into in San Diego a couple of weeks ago. There was a woman there, Samantha Heberlein, who works for Biogen, did a most professional, poised, intelligent discussion of why they thought this might work for them, why they thought the results were positive. I like her a ton, very impressed by her. But the data was not impressive to me. People tend not to believe anything that suggests you might be able to slow, stop, let alone prevent or cure Alzheimer's disease. So we need to make sure that the patients that we treat, there is no doubt that they have Alzheimer's disease. If I take a couple of patients, if I take a dozen patients with early Alzheimer's and I show that I can stop it dead, people will say, well, that can't have happened, therefore they must not have had Alzheimer's. I need to have a dozen patients that no one has any doubt about having Alzheimer's. They've got the neuropsych exams that suggest it. They've got the imaging studies that support it. They've got biochemical studies that support it. People have to be able to look at this and say, well, geez, it's still hard to believe your results, but you're right, they had Alzheimer's. I'll be darned. It's a credibility strategy for us. We need patients who have moderate Alzheimer's because we think we can cure it.
Wow, that is amazing. And Annie, just to wrap up here, I mean, what is you have a figure on a timetable to starting clinical trials at all?
We will probably be starting the FDA clinical trials next year, but frankly, it's completely dependent upon our investors. We need people to fund us through the phase 1 FDA trials. Until that happens, we can't, as it were, pull the trigger and start. We're ready to go now. We've talked to the FDA. We've lined up the people to produce the gene therapy, and we've got everything we need, the site to do it. We have people who want to volunteer for it. We just have investors who believe in it. And as I said, that's the main reason I wrote the article, was to make sure people understood that there was credibility behind this. It makes sense. It's worth testing. It's a good investment from their perspective. And yes, I think we can cure Alzheimer's disease.
Oh, it's amazing. Michael, how much money are we talking about that would need to sort of get this rolling?
It takes about $10.3 million to get through a phase 1 FDA trial, which is remarkably little compared to all the other biochemical big pharma people. But the reason is because we're aiming at the right target rather than aiming at the wrong one. It's a matter of efficiency. We can do this efficiently and easily. But $10 million is $10 million. It's certainly more than I have in my pocket or you have in yours.
Right. I want to direct everybody to Telocite, Telocyte. That is the website of the company, if they're interested in more information. And then, obviously, again, we mentioned the Telomerase Revolution, the book that's plain languaged and very easy to understand. It's a wonderful read. I really appreciate you being here, taking the time to explain these things, these sort of high scientific concepts in a relatable way. So thank you very much, and good luck to you and the company and all the work you're doing.
Nate, thank you very much. And if we succeed at that, let's talk again. I think we can do this, but the only way to find out is to find out.
Absolutely.
So that's our episode. I hope it was useful to you. Check out the show notes on iTunes or on our website where we've summarized the key points. If you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. If you have questions or comments, connect with us on social media. Finally, to support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show. That's Patreon, Patreon, patreon.com/evolvingpast. Thanks, and talk to you next time.